where you've got some real nice place to get out and spend some 10 minutes, okay? And this is, let's see if I get this to play. This was Saturday. I was up a little bit higher on the mountain. Nope, didn't want to play. But these guys are getting active too, so I was applauding the bears. Oh, it's okay. It's just them walking. Just them walking, but it was kind of cute because they had a couple of cubs right behind her. Isn't that nice?
How close were they to you?
I would say 150 feet.
Oh dear, wow.
And
Too close.
yeah. Well, anyway, that's good.
Glad you're here.
Oh yeah, no, it was great. You know, the difference, they're looking brown, but they're black bears, is what I'm told. And they look lighter brown because they're in the Sierra Nevadas and they have to adapt to the color there. But they aren't grizzlies, so I'm fine. Well, we have those outside my clinic. I've had it twice where a bear's been right outside my window. So yeah, it is interesting to be up in the mountains. All right, tools. I'm going to give a lot of props to the Million Hearts. We know that, I don't know if any of you were at our summit this last year, but we had Janet Wright there, who heads this really phenomenal organization. Founded in 2012 with CDC and CMS, really pushing for reducing events by 1 million. They wanted to do it in 5 years. They didn't quite get there, but we are learning, to get better and better, and have done a lot of good already. But this is just an e-newsletter that came out that was really, really nice. So there's so many resources. When I was looking at this and I was clicking on link after link, I was going, there's nothing I can add hardly to this. I just need to keep people aware that you can Google kind of stuff that can be so helpful. Anyway, so I even threw in there was a nice letter, an email that was sent to Hattie from another leader, Betsy Thompson, and says, hey, we're excited for RightCare Initiative and what you're doing. We're excited to work with you. So I decided I would include that because that was very nice.
Thank you.
And then when I click on that, it opens up all these tools, and I wish you could see this better, but when you click on that, it tells you about, hey, here's some ideas of how you can get that 60 to 100 minutes a week. And these are some of the various even toolkits that are available. People are doing things out there. We just need to kind of learn best practices and put this all into our processes. So it's really great. Million Hearts also has on their website this tools and protocols. Has some really great protocols for hypertension and it didn't have tons of stuff for lifestyle counseling, but lots of great other tools and things for prevention of heart disease. It's really great. And breaking news, it's also not going to start.
Without Brian's help.
Without Brian's help. No, I just thought it's only 40 seconds, but it gets you kind of excited for preventing heart attacks, I guess. So this came out just on Friday. So I'm giving you all the most recent stuff. This is exciting. The music is exciting, see? It's dramatic. I love the small steps. Sometimes we just, most people think it's just too much. I can't do that. And don't realize that every little step can make a difference. Get us started, you get some. That's my last video, so we should be good, Brian. All right. Maybe. There we go. So, as you can see, some of the stats that they're throwing out there, and this is from data from 2016, that 1 in 3 heart attacks was in relatively young people. 1 in 3. I say young because I'm getting towards the older side of the middle age, but relatively young. And 80% of these events are preventable. So that's what we're working on. This is where the events are. Okay, Now, you can see where California sits. We're kind of a little bit of a darker shade, between 951 to 1,100 per 100,000. And actually, when you look at the graph real close, we're at 999. But that's California as a whole. We're worse than that in Sacramento, unfortunately. So even though we had a decent, compared to other states, decent physical activity level, we're not the best when it comes to preventing these events. And you can kind of, I think it's interesting to look at those two in comparison. That's the same map I showed you before on physical activity and where the events are. The red on the left is where we're not doing much in the way of physical activity, and the one on the right is where the events are occurring. And don't they look somewhat similar? Okay. And so further down on that same website I just showed you, there's a link to the American Medical Association that is saying, hey, despite we've made some great strides and we've done so much improvement, but we're kind of plateauing out. And so Million Hearts has got to we're getting a little bit more robust in who we're working with, and we're going to figure out new ways to really push this. The factors of smoking are getting a little bit better. We're not doing great at blood pressure control. They say we need to get back to doing better on these ABCs. What are the ABCs? You can hardly read it, so you can't cheat. Do you know what A is in the ABCs? Aspirin, when it should be used. Okay. B, blood pressure. That's easy. C, cholesterol. Right. And that gets it. And then the S in the ABCs is smoking cessation. So they don't mention physical activity, but fortunately, what do they say that we as healthcare providers can do is right at the bottom, promote physical activity and healthy eating among our patients. Okay, so that still needs to be emphasized. And this just shows more stats of where we're really struggling on all of this. And important things to consider here. It does mention small things that can make a big difference. Let me just move on to, they also at the bottom show not only me as a provider, but we as a government and the systems that we work in, we can all make a difference. As an employer, we can make a difference. And they have suggestions here, so it's a really great resource. I think some great suggestions. Okay, let me move on. So when I've got a patient that comes in, and the old model was me telling them what they need to do differently, right? That was what I learned, that these are the things that I need to then tell my patient that they need to do for them to be successful. And that is not really work. That doesn't work very well. And so motivational interviewing is a little bit different. It is directive, patient-centered, a style for eliciting behavior change and helping patients resolve ambivalence. What does ambivalence mean, do you think? Yeah, they're just not... They're happy to just ignore, and that's how so many of us are. That's how I probably am about a lot of things too, right? And so this is a way to bring out something that I would just be happy to ignore and not even want to even let it enter my brain. So it's an effective way to talk with people about change, and so that ambivalence towards change is what this is all about. And it's really pretty darn simple. Well, first of all, you want to be, so this emphasizes the important piece of that, which is that the patient comes up with certain ideas versus the provider. All right? That motivation is not going to come, it's not going to be there if it's just me telling them to be motivated. It's not going to work. It has to be the patient. So how do we do that? Well, we start being trusted and friendly, of course. So my providers need to really focus on being trustworthy. But then these are the keys of motivational interviewing. And that is that you don't ask just yes, no type questions. You want them to be speaking and talking with you. You want to be saying things about what would you like to do? Where do you think, if there were one thing that you could change in your diet that you think would make a difference, what do you think it might be? Or if there was one way that you thought you might be able to get out or be more active, open-ended questions, affirmations. Affirmations is where you're really listening and you are supporting what they're saying. And then when we reflective listening is where we just can use what they're saying. Somebody says something, then I can say, well, talk a little bit more. So are you saying, and we can direct it a little bit that way by when somebody were to say, yeah, I don't, I don't eat very good. Oh, so you, tell me about that. And is it that you have a difficult time finding the right kind of foods, and then they can really kind of work out, and then you can summarize. So, ORs are principles of motivational interviewing. When we're talking to patients about these kinds of things, it is only going to come. All people know. I think we know inside that there are some areas that we might be able to make a difference in, and so versus telling, it's a lot of just asking, getting information, affirming, and then maybe making it pretty darn simple. I kept saying, if there were one thing, and I've had this where I've told patients, and I've just said, if there were one thing, what would it be? And they says, well, I guess I could do that. I says, oh, that'd be wonderful. That'd be wonderful. All right, so let me just finish up with process here. Hardwired for every visit. So when I, as a provider, see a patient, I'm going to be successful most of the time. This is the same thing when we're talking about controlling blood pressure and these other things. If it's hardwired into the visit. That's what you saw with EPIC in Kaiser, putting it right into the questionnaire, right? Then it's done every time. It's like it becomes our process that we're just, we mold to processes eventually. It's wonderful when a leader can then just build that and say, this is how it's going to be done every single time, every visit, short and simple. This is the hard thing for a family physician. In my visits that are very brief, relatively brief, the topic is usually not going to be, sometimes it is obviously, but usually not going to be just about diet, activity, and heart disease. It might be an ankle problem. It might be a mental health issue. And sometimes those mental health issues are overwhelming. But there's a time when it's not only that, but their pressure's 158, over 100. And then I need to address that in a way. But it's going to have to be, if I'm going to put it into every visit, there needs to be something fairly short, and it can't be all just the provider. It's got to be the team, and it's got to be standardized. At least the basics of the process are standardized. So first of all, I need to know where they stand, and we talked about the questionnaires, and I like that question, so I might implement that right there in my own practice here. So then you help them know where they stand, and be kind, but you need to be certain about the facts, okay? Meaning direct, meaning sometimes providers don't like to give people bad news or make them feel like, we've heard it already this morning. We're talking about our own providers who have said, yeah, 148, we'll just monitor it. They don't want to really get down and dirty and work on that. Then the motivational interviewing comes in. And I'll tell you, you could almost ask each of your providers to say, or staff to say, the same question. Again, it's wonderful if I can be completely tailored to that particular person, that would be awesome. But if I want this in every single visit, it might be that we have in at least 90% of the visits, we ask this same type of a question and get our providers to ask a particular type of question, which would get the patient thinking about their lifestyle. And maybe provide something that can cause them as a reminder that they could write down real quick what they just said. Okay? And then you really celebrate successes. people can have what I might think is, oh, that's really not that great. But you know, when I go, that is amazing, fantastic, then they go, oh, okay, I can do this. I can, you know, do even better. So, and then we outline where in this process, who's responsible, how are we going to do this. That data has to be collected, and that's part of our process where the, in Kaiser and Epic you saw how it happened. In our clinic it's going to be similar. And then there are certain responsibilities that the staff may be more involved in. Let me talk about what I have had success in the past with. Oh, this just told me I have to do some torso twists. It did. And it'll count them. Anyway, so this is what I used out of JNC 7 years ago when I was talking to my patients about hypertension. And I would tell them that, you know, 145 is not good, and we need to do something about that. Can you hear me?
Yeah.
Anyway, it was a drug company, I don't remember which company, who gave me the tool that I used, and of course they wanted to sell more of their medications, but it worked so well, and it was something like this. And when, you know, we found that linearly, you every time you up your systolic pressure by 20 points or your diastolic by 10, you're doubling your risk. And I would show people this with the numbers, and it was that 4 times risk thing that they're going, no. I say, yes. I'd use the word stroke, heart attack, yes. And they go, no. I said, yeah, that's what it says. So when I use those words and mention that, then people were like, oh, wow, okay. I mean, Hattie mentioned this morning, you know, saying stronger words, such as you don't want to be the one drooling out of your mouth being fed by your children after your stroke, right? I don't need to get too dramatic with them, but anyway, that kind of a thing could be something that could be handed to them. On the back side, you could have, this is just words right from the websites that I looked at. You can throw in maybe something like this, the simple sevens, which I talked about or mentioned in the very, very beginning. You can go to this in American Heart Association, you go to that My Heart score, and it takes a lot of information from you, and it tells you pretty good about where you stand with your peers. It's pretty good. I mean, I think it's interesting. So you can give them those kinds of information. I'm just going to briefly mention stress and sleep. Only enough to say that stress is bad, and that we need to do more to just get out, go out into the out and do something different, and let your decompression take you in a better place. These are just thoughts from the American Heart Association of how, when you Google, how can I lessen my stress and how does that affect my heart? It's wonderful. I could just show you slide after slide, but I'm just telling you, there's so many resources out there. The key is to find your groove and make it a practice. You'll be amazed at how quickly you may start to feel better once you disrupt the cycle of stress. A lot of great advice there. Sleep, like this thing was telling me how good my sleep was. There's some great advice. A lot of people are struggling with their tech devices and how that's disrupting their sleep. And so we may have a discussion about ideas of how you can avoid letting your tech be a problem. Tech tweaks in helping me get better sleep. You know, I won't read all of those. But again, this is just right off of a website that I could put on a card that could be easily given to a patient. And we all do this. This isn't new rocket science. I'm just saying that there's some great resources that are better than they were, I think, 10, 15 years ago. What's so funny?
Cat videos.
Okay.
Blocking the cat videos.
Oh, and so RightCare Initiative was working on a card, and in one of the versions of this card, which outlines with JNCA with the most recent guidelines on hypertension, what can we do lifestyle-wise to improve? And those are the things I'm going to show you here in different slides. So reduce weight. Look how much, if I were to reduce, if I was obese, I could drop my pressure 5 to 20 points. So there's some real numbers that could be shared with patients. We need to do the DASH diet, okay? And there's great websites on the DASH diet. And you can see 8 to 14 drop in blood pressure.
Can you just briefly mention what the DASH diet is? Because I don't think everybody in the room knows what that stands for.
Okay, so we all think of DASH diet as low sodium, right? It actually, let's go back to it. I'll show you the that same picture I had of that. Really, DASH and the Mediterranean diets are types of diets that kind of in general do the same thing. And that is that we change the types of fats we eat, that we lower, well, obviously we're lowering salt out of our diet, and we'll talk about that next after this one, I think. And increase the fruits and vegetables. How many of you are experts on, or I'm not experts, how many of you have tried, learned about these diets, and what are your experiences with them? I forgot your name.
Tanya.
Tanya.
So we actually have, in my department, we see patients that are diabetics, high blood pressure, heart failure, hyperlipidemia patients, and our nurses use the DASH diet routinely with their patients, and we try to keep them under about 1,500 milligrams for their sodium. So this is a pure practice that we use as part of our telephonic program.
Awesome. That is awesome. I don't remember what DASH stands for. Do you remember what DASH stands for?
Dietary approaches to stop hypertension.
Yes!
Woo!
Great job.
Wow. All right. Susan.
And then the other one I really associate is giving patients sort of a number to aim for. So ideally, really, it's 9 servings of fruits and vegetables. So, 3
yeah.
or 4 servings of fruit, 4 or 5 servings of vegetables, so that you come up with a total of 9. And then the thing that's really hard for people, I think, is serving size, because, for instance, the average banana we get at the grocery store is actually 2 servings of fruit. So, I think people have to see some models or hear some shorthand. When I talk to people about eating less meat, I say, like, the palm of your hand or a deck of cards, that's about how much, because, most of us eat more than that, like, that's a burger.
Yeah.
And it's like,
It's a burger.
a half a pound of meat or something, we only need 4 to 6 ounces. So, I think those are the things that are one of the hardest things in changing people's eating behavior, is that even if we say eat 9 servings of fruits and vegetables, they don't know what that means. Even if we say eat 1,500 milligrams of salt, who knows what that means. So it has to be really broken down.
It has to be down to earth.
But it does work.
Yeah.
But I think also if we just say, make your diet more plant-centric and increase your potassium with the plants, and that counteracts some of the sodium, that's a big aha moment for a lot of people, that those two things interact with each other.
Yeah.
So we want to empower them.
Right.
And this is a very empowering device, I have to say. This is my biofeedback tool.
Yes.
So our family has crazy hypertension, but I don't, because I use a home blood pressure monitor. I monitor my heart rate with this, and I know that what I eat and whether or not I have salt directly affects those numbers.
Yeah.
And if I swim 30 minutes, it keeps my resting heart rate low enough that I can get those 7 to 9 hours of sleep. I didn't know that before the biofeedback of this device. So I think we're on the cusp of a moment in the convergence of technology to make it easier to do the right thing.
Yeah.
Um,
I agree. I so much agree. Now, having this readily available and being able to implement this in our visits will be a great next step that we'll be working on, and a lot of people are working on. So we just talked about the sodium. Okay, there's your numbers. If you could count them when you're eating, but again, that's the beauty of giving people real examples. Okay? We've been talking a lot about regular activity, and again, we're not talking about going out and getting super, 50 minutes of vigorous, hard running. People are too used to now just finding a way to not take 10 steps, and it's unfortunate. It has a real negative effect.
Just a touch of reality. We can sit here and talk, we're all educated, we all have access to all of this, and it's wonderful, and how many of us actually do it, I don't know. But in my experience in dealing with patients, Sacramento, in the zip code that encompasses the state capital, has the highest heart deaths in the state, the highest degree of heart disease. But when you go into these neighborhoods, and that's the thing that's missing, you can say to somebody, take a walk. Do they have a sidewalk to walk on? Is it safe? Are you going to get shot when you walk out the front door? Or attacked by somebody's dog? Is there a place where you can reasonably walk? And you take it from there. So when we're counseling patients, it goes back to that interview of open-ended questions.
Yes.
To find out where they live and not villainize them.
Not at all.
For not
No.
doing something.
No.
I'm
Yeah.
not criticizing you, I'm just saying these are the things I run into. I had 400 migrant laborers in a study I did down outside of Bakersfield. We had no grocery stores. I never saw a physician. One came through every 3 weeks who was FQHC, he was signing off on charts. And we had to make these decisions. These people didn't have the food. We were trying to talk about diets. And we were dealing with hemoglobin A1Cs in the 14 and 15 range, which I had never seen before.
Yeah. Yeah.
So, before you can try to help them change their lifestyle, you have to help them find a lifestyle.
Yeah.
One that can encompass all of this. And we had success, but it was not easy. It was very frustrating. And I think that's what happens with I know my provider doesn't talk to me about my exercise. Maybe he thinks I'm hopeless, I don't know. But, it's that we don't have the tools to work with or how to incorporate reality with ideal.
Yeah.
And I like to bring it back to that because that's where I have spent my career dealing with patients in this aspect.
Yeah. There is nothing new about any of this, and it has been really hard to get this across. But I really want to emphasize, even though it's only 4 slides, that motivational interviewing, we call it. I just call it talking to people about change. It's really them sharing with us, because I don't know, but they will come up with some really amazing things. If you start just asking them what they think they might be able to do, then they could come up with something, and when they've come up with it, they're going to remember it. And so if there's one thing about all this to take away, one thing would be that. The other would be standardizing this into my process at my clinics, is so that we're asking the question every time, and it's just part of our process, and it's simple. I wish it were, we say 5 minutes is really what you need. That's what the studies show. I may not have 5 minutes, but I really think that doing something and talking about it and opening up that question and letting them decide and even write down what they say might make a difference. Yeah. Okay. We've talked about this, moderating alcohol intake. We talked about tobacco, smoking. Smoking is bad. All right. So, that's great. Thank you. Because I always struggle with this too. When I was asked to go ahead with this presentation, I thought, boy, I kind of think we already know a lot of this stuff. But the things that I've learned, I've talked about some tremendous resources that I didn't know were available. I'm going to work more on those kind of questions that we'll ask, and we'll train our providers to be able to ask them. More on simple and small steps that people can